My name is Christopher Shore, and I'm a fifth year MD PhD medical student. Today, I want to share with you an essay that I wrote titled Fighting for What is Right Against the Odds. Before I start reading, I just want to acknowledge your support. Thank you very much for spending time out of your day to listen to this video. It's greatly appreciated. If you have any comments, suggestions, or questions, please let me know, and maybe I can make a video in the future. All right, let's get started. Fighting for what is right against the odds. One physician's story of refusing to walk away. In the early 1980s, something malicious was just starting to bubble up in America, an epidemic that would define the next decade of public health and politics. In October 1980, a young man in Los Angeles showed up to a clinic with pneumocystis pneumonia, a lung infection typically reserved for patients on high dose chemotherapy or those with profound immunodeficiencies. Over the course of a few months, more men like him appeared across three different hospitals in LA, all previously healthy, all gay, all with severe PCP and other opportunistic infections like cytomegalovirus and esophageal candidiasis that simply did not belong to this demographic. On June 5th, 1981, the CDC's Morbidity and Mortality Weekly Report published a brief note summarizing five such cases, quietly marking the first official recognition that something new and something terrifying was happening. Within weeks, other cities started ringing the bell too. In New York, dermatologists and oncologists were seeing an aggressive, disseminated form of skin cancer called Kaposi's sarcoma in young homosexual men. These were purple red lesions scattered across the skin and mucosa. Nodes were lighting up with tumors, and lungs and intestinal tracts were being infiltrated in a way that bore no resemblance to the slower, more indolent form of Kaposi's sarcoma seen classically in older Mediterranean men. On July 3rd, in 1981, the New York Times ran a story titled Rare Cancer Seen in 41 Homosexuals, describing dozens of these cases in New York and California and noting that several men had already died within 2 years of diagnosis. To the frontline clinicians, this felt less like a pattern and more like a taunt. Why were otherwise healthy young men showing up with cancers and infections that doctors were only supposed to see on a rare exam question or in the sickest oncology wards? As the CDC pulled national surveillance data together, the numbers began to climb at a staggering pace. By the end of 1981, more than 300 cases of severe unexplained immune deficiency had been reported in the United States, with mortality rates so high that a new case often felt synonymous with a future obituary. In 1982, similar syndromes began appearing in hemophiliacs, transfusion recipients, and even newborns, shattering the early illusion that this was confined just to gay men and forcing public health leaders to acknowledge a broader blood and sex linked mode of transmission. The syndrome finally received a name called Acquired Immune Deficiency Syndrome, or AIDS, but the causative virus would not be identified for another 2 years, leaving clinicians to wage war against an invisible enemy with almost no understanding of what they were actually fighting. By the mid 1980s, the epidemic had stepped off of the page and into the exam room. Across the country, HIV doctors watched patients they knew by name vanish from waiting rooms, not because they had gotten better, but because they were gone. In Minnesota, a young infectious disease physician named Keith Henry stepped straight into the storm when he agreed to help open up one of the state's first dedicated HIV clinics at is now what is called Happen Healthcare. It wasn't a gleaming research center or a well-resourced specialty practice, but it was a cramped basement space in a county hospital where many patients arrived only after other systems had failed them. From the beginning, the work must have felt brutally asymmetrical. Henry described those first 10 years as almost overwhelming because the best he could offer was just a few extra months of life, not an entire future. New patients would come in thin, febrile, mapped with Kaposi lesions, or fighting off yet another pneumonia. And he knew before he ordered a single lab that there was a good chance that this visit would mark the beginning of their final year. He saw men his own age arrive with T cell counts that were barely measurable, chests full of opportunistic infections, and immune profiles that belonged on late stage oncology rounds, not in people in their 20s or 30s. The clinic waiting room became a place where people carried not just their pills and and pill bottles, but their grief and their fear, along with the quiet sense that much of the world preferred not to see them at all. Outside those walls, moral condemnation and open shaming shadowed people with AIDS, as if the illness itself were grounds to question their humanity. For a young physician, Henry's career calculus was obvious. He could have pivoted to a safer infectious disease niche, chased grant money and antimicrobial stewardship, or focused on transplant infections in tertiary centers where patients actually got better. He could have traded the basement clinic for a brighter hallway and a more optimistic patient population. But instead, he kept going. He kept showing up in that basement day after day for patients who often had nowhere else to go. The scientific landscape was just as unforgiving. AZT arrived late in 1987, which was a tremendous fanfare, hailed as the first real weapon against HIV. But as monotherapy, it turned out to be a more blunt and toxic instrument that just brought some people time and others it failed. Through the late 1980s and the early 1990s, Henry's clinic was full of men on complex prophylaxis regimens, cycling through hospitalizations for PCP, such as cryptococcal meningitis and Mycobacterium avium, while their immune system slowly disintegrated in front of them. He focused on the few levers he did have, such as treating the infections aggressively, optimizing nutrition where people could still eat, fighting for disability benefits and housing, and helping patients write advance directives. He did what he could. What kept him from folding his cards was a stubborn belief that if he could keep patients alive for just a little longer, the science might finally catch up. He enrolled people in early drug trials, partnered with pharmacists to manage complicated and often brutal regimens, and built a clinic culture where patients were treated with dignity, even when what he could offer could not provide a cure. He learned their stories, went to their funerals, and he came back to the clinic the next day to do it again and again. From the outside, it might have looked like he was playing a losing hand, but from the inside, he was just buying time, not just for individuals, but for medicine itself. In the mid 1990s, that long bet finally paid off for him. Protease inhibitors and combinational antiretroviral therapy had just arrived, and for the first time, clinicians had a regimen that could truly suppress the virus rather than merely slowing it down. Henry was there to see something he had barely let himself imagine. Men he had admitted to hospice, too weak to walk or to bathe, starting HART therapy, and then slowly and possibly coming back to life and having an independent life for themselves. Patients started regaining their weight. Opportunistic infections went away. After a decade of almost watching everyone die, Henry found himself extending lives not just by months, but by decades. This is what never folding your cards actually means and what it looks like in real life. It's not glamorous, it's not a Hollywood monologue or some heroic procedure. It is a young doctor chasing the basement clinic, staying with patients that keep dying, and betting that if he can keep them alive just a little longer, something will change. It's the choice to fight for what is right, for humane care, for dignity, for the possibility of a future, even when the short term signals tell you that you are losing. As someone who's gone through the rigor of medical and scientific training, I've learned how tempting it is to just throw in the cards when things feel unfair or feel stacked against you. The story of the early HIV epidemic and of physicians like Dr. Henry remind me that the real work is fighting for what is right, even when the odds look terrible. Over the long term, success is less about having a perfect win streak and more about refusing to walk away from the table when people are counting on you. Thank you for listening to this video essay. Your support is always appreciated. Please stay tuned for videos in the future. Thanks.